Morning, everyone. My name is Julien Taieb. So we are going to talk today about circulating tumor DNA for OncoDaily, and to see what are the application of circulating tumor DNA in the management of colorectal cancer in the early and late settings. So here are my disclosures. So as you know, our cells are shedding DNA in the bloodstream, and this is called cell-free DNA. And as a normal cell, tumor cell can also do that. But tumor cells have specific DNA with point mutation, gene amplification, rearrangement, methylation, specific methylation profiles. So we are now, I would say, because of the progress of molecular biology, able to detect this molecular alteration in one abnormal strand of tumor DNA out of thousands of normal circulating strands of DNA. So the first thing is that you have to understand that there are two different approaches to test ctDNA, the tumor-agnostic approach and the tumor-informed approach. In the tumor-informed approach, you need the tumor to characterize the tumor by WES or even genome nowadays, and then to look for specific mutation that you find in the tumor of your patient, that you are going to look for in the blood of your patient. So it is a long process, it is high costs, it is quite specific and sensitive. At the opposite, you have tumor-agnostic test. You are not informed of the specific mutation of your patient's tumor, and you can look at frequent mutation in the disease, like for colorectal cancer, APC, TP53, RAS, BRAF, or you can look at specific methylation that do exist in some specific cancer, like WIF or MPY for colorectal cancer. The advantage of tumor-agnostic is that it is with a rapid turnover, generally 5 to 7 days. You don't need a tumor. The test is less expensive, but possibly it is less sensitive or specific. Let's say that today tumor-informed test seems the best one in the minimal residual disease setting, so in the adjuvant setting, let's say, and tumor-agnostic test may be more performant and I would say efficient in the metastatic disease. But of course, all these tests are interesting in development and needs to be followed up to see their performance in the future with the new generation tests that are coming. So if we want to look at the kinetic of ctDNA during the course of the disease, you can see that we can imagine that in the future, if the capacity of detection is still improving, maybe we will be able to screen patients with ctDNA. It will maybe a diagnostic tool. It may be also a tool important to answer to what is the good response in the neoadjuvant setting, in addition to CT scan or other imaging methods. Then the idea is to detect minimal residual disease after the surgery when the patient is resected to see if there is still some tumor cells in the body. Then you can also detect recurrence, so it may be a surveillance tool in the future. And once the disease is metastatic, you can profile your tumor, monitor the efficacy of your first-line treatment, and also monitor the clonal evolution of your tumor. And this is particularly important in colorectal cancer for EGFR inhibitor rechallenge. What you can see first is that in very low stage disease with a methylation method here that we have published a few years ago, you have almost no ctDNA found. And if you go to the metastatic disease, most of the patients have ctDNA that is easily detectable. So the stage of the disease and the volume of the tumor will be important to detect, but also the site, because some metastatic sites, for example, are not good shedders, like peritoneal disease or like lung isolated nodules. And this is very important to be aware in this patient that when you don't find a mutation, it doesn't mean that the mutation does not exist, but maybe that you are not able to track ctDNA, for example. For screening, I will be very fast. Two New England Journal of Medicine, one in the stool, one in the blood with circulating DNA have been published this year, and probably that in the future, the improvement in this in the performance of this test will put ctDNA somewhere in the screening program, but we are not here today. It may come in the forthcoming years. Then if we move to the minimal residual disease after surgery and before adjuvant chemotherapy, it is a very important topic and probably the topic for which we have the most important volume of publication, because as you know, we are currently performing 100 FOLFOX adjuvant chemotherapy or CAPOX adjuvant chemotherapy in stage 3 colorectal cancer to help only 20 patients. And it is even worse for stage 2 patients. So in the future, having a tool that tells us these patients are going to recur and we need to treat them, and these ones are cured and we don't need to treat them post-operatively will be super important. So in an ideal world, ctDNA should be able to achieve this. When it is positive, the patient is not cured and metastases are going to occur. If the patient is negative, the patient is cured. Of course, in the real life, it's not as good as that, as you will see. The first publication by our friends from Australia and northern countries show that the performance of ctDNA is very good, as you can see on this slide. But the number of patients with positive ctDNA were 14 and 10 in these two, I would say, initial publication, but discriminating very well between patients that will recur and the one that will not recur. But you can already see that not 100% of the patient positive will recur, and not 100% of patients with negative postoperative ctDNA will be cured. So already we've seen that it's not perfect, but it's very good, like 80 and 10% respectively, which is quite impressive and better than everything we have done and seen before. The problem of these first studies, as I told you, is that the number were small, and we had recently, due to our friend of Japan and the team of Eiji Oki, Dr. Nakamura, Dr. Yoshino, Dr. Endo, very nice results showing in thousands of patients that ctDNA is a super good prognosticator. But again, even with these high numbers of patients, you can see that it's not 100% of cure in patients with negative postoperative ctDNA, and that not all patients, of course, may be due to the efficacy of adjuvant chemotherapy also, are recurring in the positive ones. So the tool is good, the best prognosticator we ever had for colorectal cancer in the adjuvant setting, but not perfect. We also have published recently because one of the questions is, do we need only ctDNA, or do we still need to mix ctDNA with clinical, pathological, transcriptomic, immunoscores, whatever, to improve their performance? So we have published recently, and this will be published in the Journal of Clinical Oncology in the near future. It is accepted that ctDNA is a very good prognosticator in 500 patients from India, France, and Greece, with a very long follow-up, which is new because all the studies I have shown you before were with a follow-up of approximately 2 years. Here we are almost at 7 years, so we capture all the recurrences in this population. And we also have tested the performance of ctDNA depending on treatment duration, 3 versus 6 months, disease stage, high risk and low risk stage 3, and immunoscore, high or low. What you can see here, and we will see the result here, is that we have also other publication that looked at the discriminating capacity of ctDNA in stage 2 and in stage 3 disease, and you can see that it is always a good discriminator, but that the prognostic by stage is still there, and that the curves for stage 3C for negative and positive ctDNA are not the curve for stage 3A, for example. If we come back to our publication, what you can see here is that in that publication, 6 months was doing a bit better than 3 months in both ctDNA positive and negative patients. That if you look to high risk and low risk, ctDNA was very good, the best discriminator again, but you can see that there is still a better outcome for T3 and 1, T1 to 3 and 1 patients, so low risk stage 3, even in ctDNA negative or positive patients. And that for immunoscore, that was not very discriminant in ctDNA positive, but in ctDNA negative, immunoscore can discriminate between patients with a 78% disease-free survival at 3 years for patients with low immunoscore versus 92% of patients cured at 3 years in high immunoscore. So it seems that ctDNA is interesting, but that we can still improve ctDNA performances with other factors. And this is another publication that we are currently in revision for the GCO, showing that with transcriptomic signatures, we can also improve ctDNA performances. So the yellow and red curves are positive ctDNA patients with good or bad transcriptomic signatures, and the blue and gray are negative patients for ctDNA with bad and good transcriptomic signatures. And you can see again that the curves are separating very well depending on these two different assessments. So in the future, if we want to reach the best prognostication for stage 2 and 3 colon cancer after surgery, we may have to combine different techniques and methods to get the best prognostication. Some meta-analytic work have been performed recently considering ctDNA. You can see that generally the hazard ratio that were between 18 and 40 in the first publication are more between 5 and 7, considering all the different methods used, tumor-agnostic, tumor-informed, methylation, or mutation. So it is not the ideal test. The current reality is good, but not perfect. And we need to see in the future how to improve that with the new generation test and with the combination of ctDNA with other prognosticators. What is interesting is that ctDNA has been now completely, I would say, included in the clinical research in the adjuvant setting. You can see that before we were doing adjuvant chemotherapy mainly on the histopathological stage of the disease. Currently, we can imagine that ctDNA will drive our treatment decision for adjuvant chemotherapy in stage 2 and 3. And the first randomized trial was published by our friends from Australia, Janti and her team. It was a dynamic study design dedicated to stage 2 patients. So this trial has a design that I called test the test. So it is not that you are going to drive the treatment by the ctDNA and randomize thereafter. It's that you are going to have standard management in one arm, and in the other arm, you're going to have a treatment-driven decision by ctDNA. So these were stage 2 patients. As you can see here on the table, when you do ctDNA, 15% of the patients were treated because positive by adjuvant chemotherapy, as compared to 28 when you don't do ctDNA by multidisciplinary staff standard management. What you can also see is that in the patient in the ctDNA guided treatment, 62% of the patients received a doublet chemotherapy with a fluoropyrimidine and oxaliplatin, as compared to only 10% in the standard management. So the intensity of chemotherapy was also significantly increased, even if 2 times less patients were treated with adjuvant chemotherapy. And also what you can see is that there is a delay of 4 more weeks to start the treatment when you do this tumor-informed test used in the trial, because you need time to get the results. When you look at the DFS curve, you can see that both arms were similar in terms of DFS, showing that recurrence-free survival is very good in both arms, and that by decreasing chemotherapy administration from 28% to 15%, you got similar outcomes. So the trial is positive. And if you think on a population-based analysis, it is very, I would say, convincing. However, if you go to more detailed analysis of the result of this trial, what you can see is that in Janti's first paper with stage 2 patients also, you have almost 100% of disease recurrence at 24 months with no treatment in this stage 2 patient. And in the dynamic trial, you have an 86% 24 months survival, recurrence-free survival, which is impressive. And I believe that FOLFOX can cure some patients, but going from 0 to 86% of cure seems very impressive and maybe too beautiful to be fully true. So there are something to explore here. And the second point is that in ctDNA negative patient, if you isolate the T4 group, you can see that this T4 group, which is here the yellow curve, has around 20% of disease recurrence, which for me is still sufficient to argue for some adjuvant therapies, because 1 patient out of 5, even if ctDNA negative, will recur. So there are a lot of different design for stage 2 and stage 3 patient. This is the Circulate French trials Prodige 70 for stage 2 and the one for stage 3 and for post-adjuvant chemotherapy. I will not detail all that because this will be too long, but you can see that for example, in this Prodige 103 trial, we are going for ctDNA stage 3 patient positive to go to FOLFIRINOX versus FOLFOX, and for the negative to de-escalate from 3 months of CAPOX to 6 months of capecitabine without oxaliplatin. So this is the way we are going to try to move forward. It is also very important to understand that in the future, ctDNA in the adjuvant setting may be primary endpoint of clinical trial. I don't know if you're aware of that, but recently FDA approved minimal residual disease clearance as a definitive endpoint for clinical trials in multiple myeloma, and this may be the case in colorectal cancer in the forthcoming years also. And this is very interesting because it may lead to more early results and to move forward to new generation therapies for patients that are resistant more quickly. If we stop with the adjuvant setting and go to the metastatic disease setting, what is ctDNA good for? First, it is interesting to find actionable genomic alteration and make the initial molecular profile of your patient. So it is already recommended in most guidelines that you can profile your tumor with a ctDNA. It is easy, non-invasive, quite fast, real-time, reflecting the current tumor status and maybe representative of tumor molecular heterogeneity. But we have to be aware that clonal hematopoiesis and non-shedding sites may also lead to some patients where you don't find any mutation because you don't have any ctDNA detectable by the current techniques. You can see that many different techniques have been published. We have a methylation technique here that is from our lab, and this is one of our paper, but a lot of different techniques have been listed and all were quite performant to profile the molecular aspects of your colorectal cancer. What is also interesting is that in recent publication, and this is a communication from Kohei Shitara from Japan, in a metastatic setting in a trial comparing panitumumab to bevacizumab first line in metastatic colorectal cancer, they have reassessed the molecular profile of the tumor by ctDNA in addition to the tumor profiling. And they have found that some patients were misclassified with some patients that were RAS mutant on ctDNA but not on the primary tumor analysis. So it is also very interesting to see that, and also that if you go to an hyperselection of gene by ctDNA, you can have a bit different result, showing, for example, that for left and right-sided patients, hyperselected and non-mutant for every resistant mutation to EGFR inhibitor, panitumumab was doing better than bevacizumab in both cases, and especially also in right-sided tumors. So very interesting results that we have to follow, and new data are going to come on that topic in the future. So genomic profiling, you can do it when tissue biopsy are not possible or inappropriate, or if you need faster results, because it's clinically important to start the best treatment as soon as possible in a patient for which the biopsy are far away from your center and may take weeks to get back and to analyze. But there are some limitations, and you really need to carefully take care of your patient, the disease burden, the metastatic disease site, and be aware of false positive and false negative. Another application of ctDNA can be early on treatments as a surrogate marker of PFS and OS, and we have already quite a lot of publication on that topic. Some of them are on the table here, and you can see that in all these publications, PFS was really better in patients with a quick ctDNA decrease as compared to those that were not decreasing their ctDNA, generally at 3 to 6 weeks after treatment start. Moving from 5.5 to 18.8 months, for example, here, to 8 to 15 months, 2 to 8 months, 1.9 to 5.8 months, depending also on the treatment setting, line of therapy, etc. But you can see that in all these papers, decreasing ctDNA quickly was associated with better PFS, and we will publish soon this trial ancillary study of a clinical randomized phase 2 trial testing immunotherapy in MSI high colorectal cancer in the second-line setting, avelumab versus standard of care second-line chemotherapy plus targeted agent. And what you can see is that the decrease of ctDNA here is the patient with a high decrease at 1 month, and here with a low decrease at 1 month or an increase. You can see that it's discriminating PFS and OS for patients treated with chemotherapy, but it discriminated even 10 times better PFS and OS for patients treated with immunotherapy, probably due to the immune response and the profile of disease response to immunotherapy with long-lasting disease control with this treatment. And the last topic I would say is to monitor clonal evolution of your tumor. And you can see here, for example, the trial from Andrea Sartori-Bianchi. And in this trial, it was shown that response in patients selected with RAS, BRAF, and EGFR ectodomain wild-type tumors before rechallenging a GFR had better response and also had better PFS and OS than what was previously published in the literature in this setting. So interesting for rechallenging EGFR to have a ctDNA assessment of RAS, BRAF, and maybe EGFR ectodomains. So the take-home messages, I would say, is that ctDNA is an independent prognostic marker that will help identifying minimal residual disease after removal of the primary colon cancer, or after the removal of all metastatic lesions for patients that are resectable from their metastatic disease. It may also help to improve forward in selecting the good patients for an adjuvant therapy and to modulate adjuvant trial with some intensification and de-escalation strategies depending on the disease. And there are, for that, at least 10 trials currently ongoing all over the world. ctDNA is recommended in routine clinical practice by most guidelines to detect biomarker for treatment decision. If tissue is not available, if you need fast results, it is a method that you can apply, especially if the patient has the primary tumor that is not resected, and if there are some liver mets not very good, if there is a isolated peritoneal carcinomatosis or isolated lung nodules where the performance of ctDNA are not so good. ctDNA may also detect, the dynamics of ctDNA may show some early resistance to some therapy and is generally predictive by its rapid decrease of the long-term oncological outcomes. It is important to use a validated and adequately sensitive ctDNA test and to discuss your results with a multidisciplinary board. And early on-treatment ctDNA dynamic predicts efficacy for chemotherapy, but also for immunotherapy. I thank you very much for your attention, and I hope you enjoyed that talk. See you soon.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.